What's a fracture? Break in continuity of bone cortex. Pathognomic signs of fracture. Abnormal mobility at site greater than crepitus. Most consistent sign in fracture. Tenderness. Causes of fracture. 1. With significant trauma. 2. Without trauma, stress fracture. Pathological fracture. Types of fracture with trauma. Transverse, oblique, spiral, comminuted, segmental. Types of forces in following fractures. Oblique, transverse, butterfly, spiral. Oblique, compression force, transverse, tension force, butterfly, bending force, spiral, twisting force. Avulsion fractures, and most common bone. Due to violent pull of tendon, avulsion of bone happens. Bone, patella, olecranon. Causes of pathological fractures. Localized -5 infection, ischemia, lesion, cyst, radiation. General 7 osteoporosis, metastatic, osteomalacia, rickets, osteogenesis imperfecta, Paget's, scurvy. Most common generalized cause of pathological fracture in site. Osteoporosis, spine greater than hip greater than wrist coals. Most common site of metastatic in bone to cause pathological fracture and investigation. Investigation, FDG PET. Site, proximal femur. Pain prior to actual fractures is seen in pathological fracture, due to microfractures, stress fracture. What criteria is used to predict risk of pathological fractures? Murrell's criteria. Score equal or more than 8 need prophylactic treatment with internal fixation. Cause of stress fracture in site. Sudden and repetitive loading of bone. Site, tibia, fibula, metatarsal. What's March fracture? Stress fracture of second and third metatarsal. Neck greater than shaft. What's IOC in stress fracture? MRI cause it identifies soft tissue edema and occult fractures also. What's IOC in multiple stress fracture? Bone scan. What's shin splints? aka runner's fracture or MTSS, medial tibia stress syndrome. Repetitive muscle contraction leads to inflammation of periosteum at site of muscle attachment causing pain in anteromedial side of leg, but X-ray is normal. What's Robert John's fracture? Fracture of fifth metatarsal base. Types of fracture healing. 1. Primary, direct healing, no callus, rigid fix. 2. Secondary, callus seen, stronger and micro movement at fracture site present. Stages of fracture healing, secondary healing, and time period. 1. Hematoma 2 to 3 day. 2. Granulation tissue 2 to 3 week. 3. Callus formation 2 to 3 month. 4. Consolidation 2 to 3 year. 5. Bone remodeling 3 years. Callus is visible on X-ray after how much time of fracture? 2 to 3 weeks. Factors inhibiting fracture healing. 1. Improper mobilization. 2. Inadequate reduction. 3. Ischemia. 4. Open fracture. 5. Old age, malnutrition, tobacco, alcohol. What's non-union of fracture in tibia? Callus formation absent for greater than 9 months. MC site, lower 1/3 road of tibia. Types of non-union. Hypertrophic, oligotrophic, atrophic. Difference between hypertrophic and atrophic. In atrophic, bone biology is abnormal, callus formation is absent and treatment is bone grafting. In hypertrophic, there is improper immobilization of bone, treatment is proper immobilization. Most common source of bone graft. Iliac crest. Ideal bone graft characteristic. 1. Osteogenesis graft makes new bone by osteoblasts. 2. Osteoconduction provides a scaffold. 3. Osteoinduction, stimulates surrounding tissue to form bone. Substitutes for bone conduction. Calcium phosphate, calcium sulfate, PMMA, polymethyl methacrylate. Substitutes for bone induction. Bone morphogenic protein, improves union. Bones with high risk of malunion. Clavicle, supracondylar humerus, Coles, intertrochanteric femur. Bones with high risk of non-union. Lower 1/3 road tibia, scaphoid, humerus lateral condyle, femur neck, talus neck. Terms displacement, reduction, traction and fixation. Displacement, movement of distal fracture segment by pulling of muscles. Reduction, bringing fracture back to normal with counterforces. Traction, counterforce applied. Fixation, maintaining fracture in reduced position. Methods for reduction. 1. Manual reduction. 2. Skin traction. 3. Skeletal traction. Manual reduction. Manual traction and counter traction done. Followed by POP application. Repeat X-ray to confirm reduction. Skin traction. Bandages wrapped, focus applied, force on skin, on soft tissue, maintain fracture reduction. Skeletal traction sites of pin. Upper tibia, lower tibia, distal femur, proximal femur. Instruments used for skeletal traction. Local anesthetic, Steinmann pin, Denham pin, number 11 blade, Bowler stirrup. Indication for use of Denham pin and Steinmann pin. Denham pin threading present, osteoporotic bone, calcaneal site of traction. Steinmann, no threading, normal bone, site of traction is tibia or femur. Procedure of upper tibial skin traction. 1. Site preparation. 2. Local anesthetic. 3. Stab wound 2.5 below and behind tibial tubercle. 4. Dilate wound by artery forceps. 5. Pin placed and drill in. 6. Pin drilled out. 7. Drill removed and wound dressed. 8. Bowler's stirrup mounted and locked. 9. Weight applied by ropes. 10. Part Montez on a splint. Complications of skin traction. 1. Staph aureus infection. 2. Pin tract sequestration. Types of temporary management splints. 1. Thomas splint. 2. Bolar and Braun splint. Thomas splint. Fixed traction device, has both traction and counter traction. Most common use, femur fracture. Bolar and Braun splint. Sliding traction device. Traction is weights, counter traction is gravity. Location of pulleys. A for tibia fractures, B for femur, C to avoid foot drop. Russell traction. Done in intertrochanteric fracture of femur. Definitive treatment for intra-articular fracture, articular surface involved. ORIF, open reduction and internal fixation. Definitive treatment for extra-articular fracture. Weaken closed reduction and POP application, but surgery is definitive treatment. Definitive treatment for extra-articular fracture of upper limb. ORIF. Definitive treatment for extra-articular fracture of lower limb. Close reduction internal fixation. CR plus if is done using reduction by C-arm image intensifier. Fixation, rod nails passed into medullary cavity of bone, interlocking screws placed. Management of avulsion fracture. ORIF with tension band wiring.